a relatively young patient. He's 75 years of age, and he has otherwise arterial hypertension, hypercholesterolemia, and he had prostatectomy for a prostate cancer issue 8 years ago. And the patient, it's maybe interesting, it's he has a normal ejection fraction, 60%, but he has a very high gradient. So he has a mean gradient on echo of 80, and a peak of 105. But despite that, he is actually asymptomatic. So, okay, so he's asymptomatic, but he has extremely high gradients and he has left ventricular hypertrophy with diastolic dysfunction. So we still take this patient in consideration for treatment. And he also had an invasive coronary angio. Not all of our patients have. I would say only half of the patients have it nowadays, but he had on CT already a suspicious lesion. And that was confirmed by invasive coronary angio. He had a stenosis on the circumflex artery, for which he was treated recently with a drug-eluting stent. So he's on double antiplatelet therapy. And then for the rest, his renal function is good, EGFR of 74. ECG, well, ECG is sinus rhythm. He has a PR which is 190. He has a borderline QRS of 110 with a left anterior fascicular block, so he's at an increased risk of pacemaker. That's the reason why we're probably gonna pace him on a right ventricular pacing wire and not on the wire in the left ventricle. And then on the CT, I can tell you that he has a perimeter-derived mean diameter of the aortic annulus of 25.3. So in this particular case, we were thinking of using the Navitor self-expanding transcatheter aortic valve. So then it would fall into a 29 millimeter Navitor. And I can tell he's very calcified indeed. And he has especially a lot of calcium. I can maybe show that here. So he has a lot of calcium all over on his 3 leaflets. But especially into the commissure between the right and the non, so it's really concerningly a lot. It's severely calcified. That's also one of the reasons his calcium score was above 3,000 on CT, and that's actually an official. If you have a calcium score of above 3,000 in an asymptomatic aortic stenosis, that's another reason to go for treatment of your patients. And then the vessels are quite large, I would say. And they're looking good, the access puncture side, but on the other hand, he has that angulated, the angulated arch. Aortic arch is a little bit Gothic arch, or I would say it's at least a sharp angulation. Okay, so that's it. I'm gonna scrub in as well. I'm gonna make ready. We can go to the table. Okay, let's put him. All right. Okay, somebody holds really well the wire, please. You can give me a little bit of wetness, something so we activate the hydrophilic coating. Yeah, that's good. All right, let's go in. Now something dry too. Yeah, to push it. Hold the wire, please. That goes super smooth in. It's a fantastic sheet. Of course, I'll cross in the wire. I'm not. Maybe we could do an effort to reposition, or we can look in the REO again. Yes. Okay. Let's go more in the cuspola. Go a bit up in the REO cuspola. I think that wire even got a small kink or something. I think I feel a lot for changing it to another one. But give me first a suture. Kan we voor in nu Lundquist? Or maybe we don't need a Lundquist now. We can do it with the Safari now. Yeah, just Safari then. A small, yeah. No, correct. And just quickly attach it to the skin so it doesn't flip out, slide out. That's it. It doesn't need an advanced knot. Right, that's enough. That prevents that it flies out. Yeah. All right. Okay, now good to go. So you keep the wire in for now. Yeah. This is now that long dry seal. It will help us getting some more pushability also on these balloons, because we couldn't push any of these balloons. He's a rather tall man, yeah. Okay, let's bring in then the pigtail. Yeah. You have the wire, Gabi?
Yeah, I do.
Yeah. Pigtail, please. All right, good. We have an Osipka 22. All right, good. Give 2 dexaheparin. Yeah. Because it takes a little bit longer than normal, the procedure, so let's give a little dexaheparin. Okay, we repeat it once for sure again. For sure, double, maybe triple. All right, we do have to do it again. Okay, face on. Yeah, go. Go, 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 go. Yeah, and down. And stop base. Yeah, should be enough. Okay, we do it once again. It's so extremely calcified, I'm just scared that the valve won't open. I think, okay, good. We repeat it last time. Facing on. Yeah, it's good. Go up. It's good. Down. Stop. Base now. All right, let's remove it now. Keep the wire in a nice position there. Yeah, we're there, we're there, we're there. But still we know that it's not in the bottom, eh? But okay, it's probably impossible. It sits actually otherwise super nice, eh? But... Sorry? You can replay it because this pressure is really good. Ah, but of course in an extreme LAO, you can go to the previous one, but still I admit. Let's put it, try to put it 2-3 millimeter lower. It's easier said than done. Because here it looks really not too deep, eh? But okay, okay. We will probably need some pacing, eh? Pace already 120 maybe. Because it's annoying that my pigtail is not really good. Hey, pacing. 120 pacing, please. Alright, it came even super annular, so it's maybe good that we resheet it. I have to do this here. Oh, we can't even get the whole thing in. It's problematic. Maybe I'm getting it lowered like that. It's not nice. I can't resheet the whole thing. Then I have to do old way. Milk it in. No. Let's see if it opens up. I can't resheet the whole valve, but then it may still be supraannular, you know, that's the problem. I think it is. That's the problem. I thought that was not an issue anymore in the Navitor. Keep the wire in. Yeah, we'll pull it a little bit in the ascending. Pull it back, pull it back, pull it back. Yeah, okay. Let's see. I can do now a bit more on the wheel. Oh, it's broken or what? Looks like it's broken. It wasn't... In the old days you could... Maybe we need a new valve because seems like it's damaged. Yeah, can we get a new valve please? No? Okay, let's pull it out. I think we have to come over that arch with the whole thing, keep the wire. And then in the abdominal it's much more forgiving what we're doing. Yeah, alright, good. Let's try to manipulate now, but you keep an eye on the focus on the wire. Yeah. Maybe I can try to. It's even completely stuck. I'll try to. It doesn't get into the sheet, I think. No. We'll have to take the whole thing out, I think. Not a new dry seal, please. 20 French. Nee, det krijgt hij. Nee. Het is een oude test. I could have accepted the first position. Really? I think it's... We would have accepted the first position. Even though that was not this one. Yeah, that high one. High position. No, that's okay, rather low. Okay, we'll get it out. Yeah, but all the time. It's all the time. I don't know why. We prepared a new valve, yes. Okay, let's do that. But let's do this under fluoro because it's that we don't tear anything. Oh, we have to keep the wire also in. Okay, good. Let's hook it out. Yeah, tack. Okay, let's take it out. Wait, keep the wire. Yeah. All right, good. Dry seal on, please. Remove. Don't throw it in the bin. Keep it. Okay, then we start from scratch here. Hold the wire, please. Maybe something to activate the coding, please. New suture also. Hold the wire. Yeah, all right, good. We keep it. You keep the wire in. Yeah, suture. Okay. Now at least the valve is much more expanded, that's for sure. So hopefully if we can get a good... Yeah, in a while. But give me first the suture. But keep it, Keep it, Yep. All right. Okay, then we were just waiting for the valve. Pressures are good actually. Maybe it's okay. Then we take. All right. We saw a bit what we struggled with. Yes, amount of calcium and maybe I have to get the pigtails back in position if the nurses are gone. This is also detached. No, everything comes here like easily back. Oh, what? Oh, God. Luckily we could nicely correct this. Did you keep it? No, the best toy. I think we should keep it simple here, like valve placement and then valve is really good, very good. I have the wire. Yep. Was there a misload in the first one, or what was the issue? There was also some bending in. I can show you later. But I have some suspicion there was some misload, to be honest. Hold the wire. I can go to my cuspola. I can do this here. Yeah. All right, good. You have it? Hold it. Everything is super stiff, man. Oh, God. Why is it traveling so hard? It's not traveling easy, that's for sure. I know. All right. Contrast enabled auto. Or is... Okay. Pacing on 120. Is it pacing or no? All right. Looks quite nice, no? And pigtail not too bad. It has never been so good. So okay, good. Definitely, that's perfect. Pacing 140. 160. I'll leave it, let it go like that, let it go like that. Maybe we come too high on the left, but let's see. Okay, pacing 100. Hey. Okay, looks not... Well, we have to check on the left side. Ooh, no, it's too high. It's a big aorta, that's the problem. Ah, okay, but then I go back to that angle. We have to let it sink deeper, you know. Actually, maybe the first deployment was retrospectively not that bad. I think it's, but the aorta is so big. Hopefully we don't have resheet issues now. There's some parallax in, maybe I can take a little bit parallax out. Oh no, that's... I have to move up here. Maybe not too bad. Okay, then I go just deeper and I will pull at the end. I think that's gonna be the strategy here. Problem is that the aorta is so big. Yeah, that's already better. Okay. Pacing 140, you could play a bit with the wire maybe. 160. Push me a bit on the wire. Yeah, there. 100 pacing. That's probably good. Looks better, no? We can take a shot in this view. Yeah, that's it. That's gonna be it, I think. 15. Hopefully I didn't see here. I think I'm gonna take this. Yeah, that should be it. Yeah, but then refill now. We're gonna do a slow release in the meantime. Neutralize a bit. Yeah, like that, like that. Okay, I'll go slow. I can take my time even. Yeah. Because the aorta is so big, so that valve will still like make that maneuver. So we're for sure. Let's revise. That we're for sure deep enough. Let's revise previous. Yeah, here it should be definitely low enough. And the other one, previous one. Previous. Negative. Yeah. Right. All taps are off. Didn't move. It's called in so much calcium. Maybe we should think the same. Yeah, if we could do, we can stop pacing maybe. Because I did quite a lot of repositionings and its pressure is super nice. So in a way, of course, it's a bit constrained. I don't like to, yeah, but okay. Anyway, then we can move on. Let's put the wire slowly out then. That was not an easy one to get in place, but of course we finally succeeded. So we're finished here. This was a very calcified case, really extremely calcified. I would say big chunks of calcium also in the commissures. We managed well, despite the fact that the first valve actually could not be resheeted completely. So we had to pull the entirety out together with the sheet and introduce a new sheet, a new valve. But we could nicely solve it like that. We had a great outcome, I would say, with a final implant depth of between 3-4 millimeter, no leak in this extremely calcified case. Young patient, by the way, 75 with previous PCI, so we needed coronary access. That's one of the reasons why we went for Navitor with an intra-annular leaflet position and wide, large open cells. So that's now we have still a very nice coronary access. We have a good closure. ECG looks fine and preserved. So probably this patient is going to go home tomorrow. So by this we can conclude from here in Copenhagen.